Yeah, it was changing stuff while you were gone.
Yeah, it was just going.
It was just bloop, bloop. Yep.
And now it's here. So I'll have to. Let me try to check it out. Oh, there you go. See, this is what happens when you end up having to start when you're not ready to start. I know. Yep. Okay, so we shall begin. Get this thing in my face because I don't want to get that in my bad report again. Oh, somebody must know about that bad report. Oh.
We didn't have you last month.
Yeah, I wasn't here.
Yeah.
I was out, unfortunately. So, yeah, some of y'all may know my son was killed in a car accident. Yeah. So, I'm doing the best I can. Y'all pray for us. Pray for me and my family. So, we're going to talk a little bit about our older adults. We're going to kind of focus on them a little bit more than we have in the past. I'm going to break this information down to you so that once we're complete, you'll have the information that you need in order to get this test taken, okay? So we're going to talk about positioning, and I know you all have heard this over and over again, but it's so important when we're talking about respiratory issues. We're going to talk about breath sounds, mentation meaning if they're confused. And a lot of times these patients will get confused because they don't have enough oxygen. Their vital signs, what we need to look for there, lab findings, and also the ABG's Allen test is very important. We need to know why. We need to know why we're going to do an Allen test and what it's going to show us when we get ready to draw ABG. So if you get an opportunity to work with your respiratory therapist, anybody in here respiratory therapist? No respiratory therapist, so if you get a chance to do that, it's really awesome to be able to occlude those veins and everything to see where the blood flow is going and all of that. We're also going to talk a little bit about cultures, biopsies, possibly. We'll get into thoracentesis, endoscopies. We'll talk a little bit about the mask too. We've heard this over and over again, so we'll get back into that again. Chest tubes will cover pretty good today, or not today, maybe tomorrow. Okay, so our topic contents. We're going to talk about COPD. We're going to talk about COPD till you get tired of COPD. I promise you. COPD is one of the major disease processes that we will see in this area and any other area that you might decide to go and work at, whether it be out of state, anywhere. Smokers, we have smokers, and sometimes what we're finding is that even though we don't smoke, we still can be diagnosed with COPD. The reason why is because there is a gene within us, ATT, we'll talk about that a little bit later, where people are actually picking up these different genes that will cause them to be diagnosed with COPD. We're going to talk about pneumothorax, hemothorax, chest tube insertions, and all of the things that we need to do in order to care for that chest tube. We'll get into the medications. I'll give you exactly what you need to know about the medications so that you can study without having to worry about knowing every little detail about those medications, okay? Nutrition is very important for these people. Nutrition, if you're so tired and you can't catch a breath and you can't get up to fix your meals, then you're probably not going to be eating very well. So we'll talk about what types of diets we want to educate our patients on for that. Okay? So here we go again, COPD. We're going to get into assessment, diagnostics, medications, nutrition, and phototherapy. Okay, we've already covered this. I think in level 2, we've gone over where things are located, what they look like, how many lung lobes we have, all of that good thing, all that good stuff. Like lungs are the main organs of our respiratory system. We know that. Each lung is divided into lobes. We know that we have 3 on the right side and we have 2 on the left side. If our patient has had surgery, I think I spoke to some of my groups before to make sure when you're listening, don't just say what you see or have read another nurse record. Make sure that you know what that patient's history is before you say that you have heard lung sounds in the bases of your right lung or your left lung. That way you're covering yourself. Okay? The lung has 3 major functions. Our lungs are going to ventilate. They're going to ventilate. You don't need to write this down. We're going to do respirations. Our lung provides us with respiration. And they also perfuse. They perfuse oxygen out to the rest of the body from the blood. Okay? The normal function of the lung depends on the integrity of the airway, okay, to transport air to and from the lungs. The ability of the alveoli to participate in gas exchange and a properly functioning cardiovascular system are all important in the process of breathing. Okay, so we talked about alveoli before. We talked about their function and what they're going to do to help us breathe. The alveoli, they are the basic units of gas exchange. That's where it takes place, okay? Gas exchange takes place in the alveoli. A pair of healthy adult lungs will have close to 3 million of these little alveoli floating around in there, and they look like little grapes, okay? They're surrounded by lung capillaries. This is just a review. These numerous small alveoli normally make a large surface area of gas exchange, okay? The alveolar walls have cells that secrete surfactant. We've all heard of surfactant, especially important when there's a newborn baby. When we smack them on the bottom, we want them to breathe, and once they breathe, that surfactant helps to open up the lungs and open up the alveoli so that it can help that baby to be able to breathe better, okay? Without surfactant, what will happen to the alveoli? What can happen? If they'll collapse, it's called atelectasis, okay? That is when your alveoli collapses, okay? This is going to cause reduced gas exchange because the alveolar surface area is reduced. Okay, so keep that in mind. Whenever anybody tells you a patient has atelectasis, the only thing that they're saying is that the alveoli have collapsed. Okay, so we want to make sure when we talk about positioning, we are turning our patients, making them cough, and deep breathe. And always chart. I make my patient turn, cough, and deep breathe. Okay? So gas exchange here in respirations, this is just a little bit of extra to kind of tell you what the system does. Movement of air into and out of the lungs. There are 2 phases, of course, inhalation and exhalation. We have no control over it, thank God. Because if we had little ones, the little ones hold their breath and then they fall out. So they have to at some point let go. And thank God we can, deal with that. They get back together, everything's good to go. Okay, so that's, like I said, a little bit of an extra to go along with that. But now what we're going to really talk about, and I want y'all to focus on this little area here as far as VQ ratio is concerned. Let me find my slide on that because I got a lot to cover over it. Okay. So what is VQ ratio? What does it mean? Ventilation and perfusion. Okay. The scans are not widely used anymore. Okay, keep in mind, they're not widely used anymore, but they may be considered in certain circumstances, such as with allergies, if a patient has doctor may order a VQ scan. Okay. Before discussing what happens in the mismatch, the VQ mismatch, which is going to be important, it's important to understand exactly what VQ means. Okay, does anybody know what the V stands for? The V stands for ventilation. Okay, the V stands for ventilation. The air that is breathed in through the nose and the mouth, down through the trachea, into the bronchi, and then down through smaller airways into the smallest airways known as alveoli. That's all it is. Okay? This is where, again, I said carbon dioxide and oxygenation, all of those things exchange. Okay? So then, if you know what the V stands for, what does the Q stand for? Perfusion. That's right. The Q stands for perfusion, or blood flow. That's all it is, blood flow. This is the blood flow from the heart, okay? So you have that deoxygenated or blue blood that passes through the pulmonary arteries. It passes through the pulmonary arteries, which are more like veins because they have the blue oxygen, or they have the blue blood that needs oxygen. And that's the reason why they look blue, because they're not oxygenated, okay? So they go through smaller and smaller vessels and into capillaries. The smallest blood vessels where oxygen and nutrients exchange takes place, again, in the alveoli. Okay. So I wanted to get into dead space because I think that was kind of mentioned in there as well. Okay. So understanding dead space. Okay. The only thing that dead space is it that it refers to the area which the alveoli and capillaries do not line up. Okay? The alveoli and the capillaries don't line up. You may have a few alveoli and more capillaries, or you may have more capillaries and not enough alveoli. Okay? Anatomically, dead space, which is due to an obstruction, is either the airway or blood supply, which is, or such as, in the pulmonary embolism. So that's what happens when you have a pulmonary embolism. The pulmonary embolism is obstructing a blood vessel. It's obstructing a blood vessel. It could also be a foreign body. A foreign body meaning something that may have been inhaled, like anthrax. You know, we hear about anthrax threats and things of that nature. Something that is obstructing the space. And so the dead space, again, is just where air is not able to move in and out of an area. Physiological dead space, which occurs when the structures of the airways or blood vessels are normal, but there is some reason why the alveoli and capillaries don't match up, and this it puts it in a shunting position. Don't worry, I'm gonna wrap it up before you get a nice good bow. Before it's all over with. We got to talk about this stuff in order to get to the stuff where I need you all, and I will let you know what is important and what I want you to know when it comes to test time, okay? So don't worry. These are just terms and things that I want you to keep in your head in case you happen to hear them and you hear the doctor mention that he wants you to have this test done or something like that. You kind of got an idea of what he's talking about. Okay. But like I said, he probably won't order something like this because those tests are kind of neat these days. Okay. So when we measure the VQ ratio, when we do that, it's done in two separate tests. Okay? They measure the ventilation. A person has a mask placed on their face, and they breathe in like a radioactive air. Okay? So what this does is it measures perfusion. Okay, and then the radioactive protein is injected into the veins. Then the results of the two tests are compared, and that's how they get that ratio. Okay? So only mean that there are 4 liters of oxygen that is passing through the lungs per 5 minutes, okay, or per each minute, I'm sorry. Per each minute, there's 4 liters of oxygen passing through the lungs. While on the other hand, there is 5 liters of blood that is passing through the lungs. So that would be a normal reading. 4 liters of oxygen passing through the lungs, while 5 liters of blood passing through the lungs. Okay? So now, we're going to talk about the mismatch. The VQ mismatch means that in some areas of the lung, the alveoli and capillaries do not line up. Again, that's important. In a VQ mismatch, the alveoli and the capillaries do not line up. And in essence, it is also called a dead space. This can mean that some areas of the lung, there are more capillaries than alveoli. I think we said that before. There are more capillaries than alveoli. So they would be better perfused by blood than ventilated. So they get more blood and they get more oxygen. In other areas, there may be more alveoli with fresh oxygen than capillaries to pick up that oxygen. You see what I'm saying? So it's better, they're better ventilated than they are perfused. So it could be one or the other. Either way, it causes a mismatch. All right. Okay, so I do want to continue on a little bit more on VQ mismatch because I want to talk a little bit about hypoxia before I get into shunting. I know. VQ mismatch is the most common cause of hypoxia. Remember that. A VQ mismatch is the most common cause of hypoxia and a component of most causes of respiratory failure. Okay? When there's a mismatch, there is a problem which is going to cause a respiratory failure. Hypoxemia, that's another word that we know, because that's no oxygen in the blood, right? So hypoxemia is a term that refers to a decreased level of oxygen in the blood. When the cells of the body are deprived of oxygen and become damaged and ultimately die due to hypoxemia, it is then termed hypoxia. Of course, just to review. Symptoms of hypoxia may be faintness. We need to know this. Symptoms of hypoxia may be faintness, shortness of breath, confusion, and if it's untreated, it can be death. Okay. So now we're going to move on and we're going to talk a little bit about shunting. Okay? The hyperventilation triggered by hypoxia and pain first leads to respiratory alkalosis. I know y'all probably have heard something about fluids and electrolytes and ABGs and all of that, and respiratory acidosis, respiratory alkalosis, and all of that. So in shunting, hyperventilation triggered by hypoxia and pain first lead to respiratory alkalosis. This is indicated by low partial pressure of arterial carbon dioxide, or PaCO2. On arterial blood gas analysis, the PaO2, or oxygen, it's okay. The PaO2, or oxygen, fraction of inspired oxygen ratio falls as a result of shunting. Okay? The blood on the right side of the heart shunts The blood from the right side of the heart shunts to the left without picking up oxygen from the lungs. So that's to wrap it up in a little bitty bow. Shunting, the blood moves from the right side to the left side without picking up oxygen. That's the main thing that I want you to know, okay? Move that. So again, just to review, just so we know that you have all of these little pieces of the puzzle together, you can see here in the lower respiratory system that normal ventilation goes from high pressure to low pressure. The diaphragm is an important factor. And when we're talking about the elderly, how we said we were going to focus a little bit on the older people, we think about what the chest looks like, the diameter of the chest. Is there any changes? Do you see barrel chest? Those kinds of things. If those are compromised, then breathing is going to be compromised. Okay, so we have lungs that need help. We're going to talk about COPD again, emphysema, and chronic bronchitis. And you know what COPD is, right? It's just the umbrella. Okay? Okay, the etiology and genetic risk. There are etiologies and genetic risks. Cigarette smoking is the greatest factor for COPD. We know that. The patient with a 20-pack year history or longer often has early stage COPD. Keep that in mind. Someone tells you they've been smoking for quite some time. They'll probably you'll probably want to look at their history, and you'll probably know that they'll have early stages of COPD. Okay? They're going to have changes in their pulmonary function test. You'll see that on your PFTs, okay? The inhaled smoke triggers the release of excessive proteinase in the lungs. Okay, boring stuff. These enzymes break down elastin. They break down elastin, the major component of the alveoli. So that's what happens when you smoke. The alveoli can only take so much. And then through that, they begin to deteriorate. And they're not like our liver. They don't regenerate. Okay? By impairing the action of cilia, this is what happens. The cilia gets impaired, okay? And then smoking also inhibits the cilia from clearing the bronchi, okay? So if the bronchi is not cleared, you're going to have this mucus buildup. And the mucus buildup is going to present with a cough. So you'll see these patients, they'll cough a lot, okay? So we talked about AAT. The enzyme is called alpha-1 antitrypsin. Alpha-1 antitrypsin is ANTITRYPSIN. Alpha-1 antitrypsin. Okay, this is normally present in the lungs. Okay, ATT inhibits excessive proteinase activity so that proteinase only breaks down inhaled pollutants and organisms and do not damage lung structures. You don't have to write all of that. Okay, it's in the book. The production of normal amounts of AAT depends on the inheritance of a pair of normal gene alleles, okay, for this protein. The AAT gene is recessive. This is good to know. When you have, the reason why I'm telling you this is when you have a patient who comes into you and they say that they have been diagnosed with COPD, but they've never smoked and they've never been around people who smoke. That's the reason why I want you to be aware of this, is that there may be a gene in their family that causes them to possibly still be diagnosed with COPD. Okay? All right, so when you, I would be like, if it was me and my patient said, well, I never smoked, why is this happening to me? And I would probably be like, I don't know, why? I would think that you would have been a smoker if you're diagnosed with COPD. Okay? So AAT it used to prevent COPD unless it prevents COPD unless there is significant exposure to cigarette smoking or other inhalation irritants. Okay? This person, however, is a carrier for AAT deficiency. The person who is diagnosed and never been around anything like that or any cigarette smoker, that kind of thing. So they have a deficiency. Okay? When both alleles are faulty, COPD develops at a fairly young age. Okay? They can get it young. Okay? Even when the person is not exposed to cigarette smoke, just like I just said, or other irritants. So there are about 100,000 Americans who have severe AAT deficiency. So, be aware of that. If they're deficient, they have no protection, and they could possibly be diagnosed with COPD. Okay? So ADLs are important to note because it is life-altering when someone suffers from a chronic illness, especially one like COPD. They become depressed, they become dependent, they become despondent. Those are my 3 Ds. And those are the things that we want to look for in our older people. They get depressed, they get dependent, they get despondent. Okay? They feel like their quality of life has been altered, and therefore they may retreat. They may not want to express their feelings, and they may have a sense of guilt because of family members who have to care for them. So when we're doing our respiratory assessment on these patients, we want to ask them questions. Ask them, about their lifestyle. All of these things that you all have already been exposed to. Examine them thoroughly. Listen to the lungs. Ask them if they have had pneumonia, or if they've had the pneumonia shot, or if they've had their flu shot. Those are things that are very important for these patients. Okay? So we're going to talk about constriction, compliance, and volume. And the reason why we're going to talk about that is because we have several disease processes that fall under the category of constriction, compliance, and volume. Do you all know which ones fall under constriction? Asthma, constrict. What about bronchitis? Bronchitis. It's a constricting disease process. And emphysema. Emphysema is a constriction. Okay, in an obstructive lung disease, airway obstruction causes an increase in resistance during normal breathing. An increase in resistance during normal breathing. The pressure-volume relationship is no different from the normal lung. It's no different. However, when breathing rapidly becomes greater and the pressure needed to overcome the resistance, what will happen is they'll breathe in, but they're trying to breathe out faster than they're able to breathe in. Okay? And then two, they have all of the irritants and the disease process and the coughing and all of that. And we know, like in bronchitis, it's an itis. So if it's an itis, there's inflammation. The bronchioles become inflamed and they begin to constrict. An asthma, if anybody knows someone who has asthma or has anyone here has asthma, you know that when you're exposed to an irritant, your bronchioles and all of those, the trees become constricted because it cannot breathe properly. Okay? So when they cannot breathe properly, what types of meds do we give them? Bronchodilators. They need something to open up that airway. That's correct. Okay? So compliance. What types of illnesses do we think would be considered under compliance? Maybe pulmonary fibrosis, pneumonia. Pneumonia might be considered under compliance. And then pulmonary edema. And here's why. In a restrictive lung disease, the compliance of the lung is reduced. The lung compliance is reduced. okay? This increases the stiffness of the lung. The lung becomes stiff, okay? It's stiff. And the lung it is limited in its expansion. It can't expand, okay? So it can't expand, and then you have greater pressure than normal is required for the same increase of volume. So common diseases or causes of decreased lung compliance are pulmonary fibrosis, like we said, pneumonia, and pulmonary edema. Okay? So in this one, you have the stiffness of the lung. Just know that you have the stiffness of the lung when you have a compliance problem. Okay? And in volume, if there's a volume problem, I think about there's something in that lung that is taking up space. So what could be taking up space in a lung with a volume problem? Fluid. Yes. Fluid, like as in pneumonia. You have all of this fluid that builds up in the lungs. What else? What about cancer? A tumor. Absolutely. If you've got a tumor in lung cancer, it's taking up that space, so you have a volume problem. There's no more room in there for anything else because you have either some kind of fluid or you have some kind of tumor. Absolutely. Okay.
Can I ask a quick question?
Surely.
For like your pneumos and all that, where would, or atelectasis, any of your collapsed lungs, where would that fall?
Like pneumonia?
No, tension pneumothorax or hemopneumothorax.
Oh, we don't get into that. It's going to
Okay,
be...
so it's not one of these.
Not so much so, but we'll get into that and we'll talk about that a little bit later. Probably won't get to those until tomorrow.
Okay.
But good question though. Yeah, we'll cover that and I'll go over that thoroughly with you. Okay. All right, so let's look at, before we take a break, because I know I'm killing y'all, and I'm sorry for that. Chronic bronchitis. Chronic bronchitis. Okay, what can y'all tell me about chronic bronchitis? Yeah. Some people have acute bronchitis, but when it lasts longer than 3 months, then we consider it chronic. Okay, so chronic bronchitis is an inflammation of the bronchi and the bronchioles. Okay, so they're inflamed, and this is caused by exposure to irritants, especially, again, cigarette smoke, okay? The irritants triggers inflammation, vasodilation, mucosal edema, congestion, and bronchospasms. Okay, when you get those bronchospasms, you'll hear people coughing, constantly coughing all the time. That's because their bronchiole is spasming. Okay? Bronchitis affects only the airways. Keep that in mind. It only affects the airways, not the alveoli. Okay? All right, chronic inflammation increases the number and size of mucus-secreting glands, which produces large amounts of thick mucus. So that's where you get that thick mucus from. The bronchial walls thicken and impair airflow. There's a good picture of that. How it shows the bronchioles, how they close up, and then you can see, like in that little star that's on the second one, how it has the mucus and all that stuff like that that's in there, and then they cough up, and they cough up all of this stuff, especially in the morning. A lot of times you'll hear them coughing, and they'll have that thick mucus. The bronchial walls get thick. They get thick and they get impaired. And so your airflow, they're not able to breathe as easily as they should. Okay? This thickening, along with excessive mucus, blocks some of the smaller airways and narrows larger ones. Okay? It blocks smaller ones and then it narrows the larger ones. The increased mucus provides a breeding ground for organisms. So these people are highly at risk for getting infections. Okay? leads to chronic infection. So they're constantly in the hospital with some type of bug that needs to be treated. So to wrap it up, chronic bronchitis impairs airflow and gas exchange because mucus plugs and infection narrows the airway. Okay? As a result of all of this, your PaO2 levels will be decreased. So think about it. You got chronic bronchitis, PaO2 is decreased. So what do they have? Hypoxemia. They get hypoxemic. Okay? And so the carbon dioxide levels increase. In chronic bronchitis, you get hypoxemia, okay, because you don't have enough oxygen. And then you get an increase in CO2 because you can't blow it off, which leads to respiratory acidosis. Okay, respiratory acidosis. And this is a problem with constriction again. Bad X-ray. Bad X-ray. Okay, alveoli and emphysema. Y'all want to take a break? Y'all feel like you need a break from me right now? See, I added that little extra over there after that. Let's see what time is it. Now we can keep going. We'll keep going. Let's see. So we're going to talk about emphysema. I don't want to get them both kind of mixed up there, so let's get into it anyway. Emphysema, the two major changes that occur with emphysema are loss of lung elasticity and hyperinflation of the lung. So you get a loss of elasticity and hyperinflation. These changes result in shortness of breath or dyspnea. And there is also reduced gas exchange. Reduced gas exchange. And there is a need for an increased respiratory rate in these people. So you'll find that your respiratory rate, they're going to be tachypneic. Okay? You'll find that their respiratory rate is higher. Okay. Cigarette smoke triggers increased synthesis of enzymes, proteinase. When these proteinase are present in higher than normal levels, they damage the alveoli and the small airways by breaking down elastin. They break down elastin. You don't have to write that. Over time, alveolar sacs lose their elasticity. They lose their elasticity, and the small airways collapse or narrow. This is happening in emphysema. Okay? Some alveolar are destroyed, and others become large and flabby. So you got all of these alveoli in there, but they get bigger, and then they get flabby, and they don't work anymore. They're destroyed. They have less area for gas exchange. That's important. You know, they have less area for gas exchange because they're damaged. So then you have an increase of air that is trapped in the lungs. Overstretching and enlargement of the alveolar or air spaces called bulla. They're called bulla. And they collapse. They collapse the small bronchioles. The small bronchioles become collapsed. So what happens, to wrap it up, is that the changes greatly increase the work of breathing and interfere with airflow to the lungs. So the person has to work harder to breathe, and their oxygen levels are decreased. So here you have a problem of compliance again. you see here on this slide, it shows how a normal chest looks as opposed to a person that has a barrel chest, because the work of breathing and the changes, the diaphragm changes. So you'll see that in your patient who may be diagnosed with COPD. And then their x-rays are going to look off. Of course, I don't read x-rays, so, I leave it to the x-ray techs to kind of run that by us and tell us what's going on. But you may also see your patient when they're sitting in the chairs. You'll see the work of breathing is hard. You'll see accessory muscles being used. The hyperinflated lung flattens the diaphragm. That's what happens. It flattens the diaphragm. Okay, it weakens the effect of the muscles. The muscles become weak, and as a result, the patient with emphysema needs to use those accessory muscles in the neck. You'll see them breathing, their neck will be protruding. You'll see veins and stuff popping out in the neck, okay? The chest wall, they're using their chest wall. Their abdomen, they're using the abdomen to inhale and exhale. And all of that constant use makes for these changes, okay? These patients become air hungry. That's what we call an air hunger when they're breathing in that manner, okay? Inhalation starts, again, with these patients. They inhale, and they don't have enough time to use that inhalation before their exhalation. Exhalation is going, so it's, yeah. So constantly you'll hear like that. And then they're at risk for hyperventilation as well. Okay? So, we're going to talk about assessment. And this is going to be a pretty good lot of stuff when we get into the health history and all of that. So we'll talk about that. And let's take a minute and breathe and just reboot. And then we'll come back and talk about it, okay? So let's take a break. 10 minutes.